of our endometriosis talk. Everlasting Beauty by Jennifer, jump over to Facebook Live. Ray Doman, jump over to Facebook Live. 22 Love, jump over to Facebook Live. Natural Tay, jump over to Facebook Live. We're going to be doing a talk today on endometriosis, and then I'll come back to some questions. Just Something Auntie, jump over to Facebook Live. We're going to be doing talks over there. Texas Wieners, jump over to Facebook Live. Welcome. We're going to be doing a talk on Facebook Live today. So please, if you want to listen in on that talk, you may. You can see I'm going to having some slides. So we're going to do part 2 of our Facebook Live. So the Queen 18, jump over to Facebook Live. KEDXOX, jump over to Facebook Live. Hi, Michael. Happy to meet you. I'm so glad you're jumping over. Caitlin, of course, hello, good morning, or good afternoon. I guess it is the afternoon. So everybody on Instagram, please jump over to Facebook Live. Hey, Alma on Facebook Live. Hello from New Orleans, Natalie. Pretty Girl Welsh, hello there. Hello, Dr. Mag. This is Shante. Hey, Shante. Vanessa, thank you for bringing about the whole Facebook Live thing. Good evening, everybody. So all you folks who are on Instagram, please jump over to Facebook Live. Oh, thank you. Most of you have already jumped over. I love that. Wiselanda 1018, we're going to be talking about endometriosis. This is a second in our series. So it's going to be, hello, Sarah from Florida. Hello from New Orleans. So anybody on Instagram, jump over to Facebook Live, CMY Facebook Live, or I guess YouTube channel 2 is live. So jump over, and we're going to be talking about endometriosis. Alma, hi from Arizona. I spent a lot of time in Arizona. Brandy, hello. Vanessa, thank you. Join Facebook. Actually, folks, Vanessa Rodriguez, there's a CNY Facebook group. Please jump over. The whole goal there. Anybody who's on Instagram, please jump over. Porsche, Kelly Below, Flawless, AKA 7 Demai. Isha, jump over to Facebook Live. We're going to be talking about endometriosis today. So if you're on Instagram, jump over to Facebook Live. We're going to be talking about endometriosis today. And then later on, of course, we'll take questions and answers. And I try to talk about the slides out loud. But if you're on Instagram, jump over to Facebook Live because it's just a much better experience. You get to see slides. Jennifer, welcome. Lindsay Morrow, hello. Good to see you. Vanessa, thanks for all your support about the CNY fertility group. Muchin, jump over to Facebook Live. Jen Morales 87. Deep Trick, jump over to Facebook Live. We're doing a talk on endometriosis today. So every other week I do a talk, and so this week we're doing it on part 2 regarding endometriosis testing. We're going to be talking about traditional Chinese medicine. We're going to actually be talking a little bit about endometriosis diet. Endometriosis happens to be one of the top gynecologic disorders in women, and we're going to talk about it because there are a lot of folks who have that, and there are a lot of folks who don't know they have it. So all you wonderful folks on Instagram, Marisette16, Josie113, SARS Gris World 2423, Purple Pink Roses 42, Linabelle 77, Kimmel 03, jump over to Facebook Live, okay, folks? You guys on Instagram, jump over to Facebook Live. We're going to be talking for quite a bit on endometriosis testing, traditional Chinese medicine, dietary management, some treatments, with my goal of continually helping you get a better grasp on the various diseases associated with infertility. And some of them are known, some of them are not known. And what I think I'll do, if it's okay with you folks, all you folks on Facebook Live, all you folks on Instagram, jump over to Facebook Live because I'm going to be talking about it. So I'll, to save my voice here, if everybody can tell everybody else to jump over to Facebook Live, that would be great. And then I will answer questions after after I do my little talk here. So let's talk. So how do we test for endometriosis? Now, there's a lot of details on this slide, but the key thing is that endometriosis is a diagnosis, as I've described before, that's a surgical diagnosis, and it represents the lining of the uterus that has been regurgitated out the fallopian tube and has caused it to implant inside the pelvic cavity, such that it can cause structural problems, pain problems, immune system problems, inflammation, infertility. And so the gold standard for determining if you have endometriosis has always been and still remains a surgical diagnosis with laparoscopy. However, what they have found is there's a tumor marker called the CA125 tumor marker. It's used for epithelial ovarian cancer, but it's also a marker of inflammation, and it still remains that a marker for endometriosis. Now, I think the best way to use it is not to determine if you have endometriosis, but to follow the severity or the return of endometriosis. So the short answer to all the testing, and I'll talk about Receptiva and others, is that the gold standard is still surgical. So here we get to the development of a non-invasive DNA test may help direct symptomatic patients to specialists. So here again, in this abstract, they're basically saying that there are markers. However, you have to have a select population of patients with symptoms. And we talked about those symptoms: pain with intercourse, really painful periods, masses and nodularity on the bimanual exam, masses seen on ultrasound in the ovaries. If you have that state, then a DNA test may be helpful since it's non-surgical. And it did lead to some other ways of detecting endometriosis, which we'll see again in the Receptiva tests. Here's another study looking at the accurate doses of endometriosis using serum micro or recombinant RNA. And it was able to differentiate endometriosis at about a 90% likelihood. It may help get us quicker to a diagnosis of endometriosis in folks who don't want to go through surgery or they don't want to have the risk of surgery. But again, it's more of a trend analysis as opposed to a true diagnostic test that anyone can take. So that leads us to the endometrial BCL6 overexpression. This is the Receptiva test, and people talk Receptiva DX, that's the true name of it. The Receptiva DX test was started by a friend of mine, Dr. Bruce Lessey. He and a group of others found that the expression of this tumor, of this inflammatory marker, seemed to be a fairly good indicator of inflammation of the uterine lining associated with endometriosis. What they found was that if those women had this test and it came up positive, they were 5 times less likely to achieve a pregnancy with IVF. So in a way, it's if a person fails, again, you have to have symptoms, you got to have a problem. So if you're already in infertility care and you're not getting pregnant with IVF, then it may be, and I tell you, Dr. Kiltz is a strong proponent of this, if you're not getting pregnant after 1 or 2 embryo transfers, especially if the embryo transfers are chromosomally normal embryos, then doing this Receptiva test may get you to surgery, but even then, it's not 100%, so getting to surgery is probably a good idea. So the creation of this Receptiva test really was an important shift in how to look at endometriosis in women who had what we call cryptic or hidden endometriosis. So this was another study where they looked at, again, it was by Dr. Lessey and his group, and they found with women with low levels of this BCL6 or Receptiva DX test had significantly higher pregnancy rates compared to those who had abnormally high levels of expression. Also, the live birth rate was significantly higher. So their suggestion, again, we have to watch how this is said. Their suggestion was that this expression was strongly associated with poor reproductive outcomes in women with unexplained infertility. So again, when you're doing these tests, it's not the test for endometriosis. Surgery is that. That's both diagnostic and therapeutic, but it may be something that may suggest why you're not getting pregnant with IVF. Another group, the Najat brothers. The Najat brothers are they sort of created the Najat Institute for Minimally Invasive Robotic Surgery, and so they're really interested in endometriosis, and they wanted to know does this test have a positive predictive value? So that's the point. They're saying, can we use this to predict which patients, if we go to surgery who have symptoms, will have endometriosis? And they found that about 80% of women who had a negative, it was useful in about 80% of times to predict that this patient you're taking to surgery for other symptoms actually has endometriosis. So the suggestion was we may be using this as a tool. And again, the Najats also did another abstract talking specifically about that. They also found that this marked inflammation in those women who ended up getting surgery, even if it wasn't endometriosis. So it could have been pelvic infection, it could have been fibroids, it could have been something else. So it's kind of a new tool. It's out there. People are ordering it. We certainly do at CNY Fertility. We do this test for folks. Typically, we reserve it for folks who failed, basic IVF, and we didn't have a reason. But then we have, this is again another study by Dr. Alessi, which basically says in unexplained pregnancy loss. So now we're talking about, let's say, a biochemical pregnancy, or a missed AB, or a spontaneous abortion, or miscarriage. What they found was that in these patients, you could predict using the BCLL6 testing, those patients who have these unexplained pregnancy losses and end up getting surgery, they find endometriosis. So endometriosis is the hidden cause of unexplained infertility, meaning, we're doing IVF, we're not getting pregnant. To keep doing IVF in those circumstances is not going to be a positive thing for you, because essentially you're not getting to the root cause of your infertility, and the IVF is not going to fix that. So you will find that with CNY docs, we tend to ask you, when you ask us, hey, why didn't my IVF work? The first question I'll ask is, okay, have you had an endometrial receptivity assay? In other words, an ERA, because we want to make sure your lining is capable of carrying a baby. If you haven't done that, then we recommend it. The second thing I might say is, hey, have you had diagnostic laparoscopy to tell whether or not you have endometriosis, and was it treated? If you haven't, then I would strongly recommend it before you put in all those wonderful embryos you have frozen. And it's very hard. You've already gone through a procedure. You're tired of being poked and prodded. But if you're not getting pregnant after doing a very successful IVF cycle, meaning you're getting embryos, it may well be that you have hidden endometriosis. Now, the folks on Instagram, like Jane and Carmel and Demonda, jump over to Facebook Live, because that's where I'm doing this lecture, and then I'll come back to questions. But like anything in medicine, you have a counterpoint. And Richard Scott, who's a very famous reproductive endocrinologist researcher, he looked at and he always does gigantic studies. In other words, he never does small studies. He does tens of, sometimes thousands of patients. What he found is that this particular test is not perfect, essentially, is what he's saying. They did not find that it positively correlated with those with IVF outcomes, this actual test. So using this test simply, the Receptiva DX, to see whether or not you're going to have a positive or negative outcome, or that outcome would continue to grow, they found no differences in those who were positive for this BCLL6 and those who were negative. So what he says a lot of times is that we're not there yet. We don't have the studies yet. And that's why you'll find that I'm very tentative on making and having my patients do all these tests, because A, they're very expensive, and B, the data aren't there to say that it actually supports the contention that you see in the marketing materials. So Receptiva DX, of course, is being marketed widely, and their hope is, of course, everybody uses the test many, many times, but it's not inexpensive, the test. Here's another, here's an interesting study looking at, can we do treatments like Lupron, downregulating the agonist treatments on our patients, and will that change the outcomes? And in this study, what they found was that that there's a high correlation between this BCLL6 antigen and the diagnosis of endometriosis, which is what we knew. And then what they looked at is that they found that if they treated the patients with Lupron, their actual implantation rates went back to what they should have been. So what they're basically saying, by the way, all you guys on Instagram, jump over to Facebook Live, because I'm doing my talk on Facebook Live. I can't get it on Instagram yet. It doesn't work that way. So jump over to Facebook Live, jump over to YouTube Live, and you'll be there. But my point about this is that they have found, and this is what we've known about treating endometriosis, is that once you treat it surgically, 3 to 6 months of Lupron downregulation of the estrogen receptor, removing estrogen, I should say, from the body via the downregulation of the GnRH agonist, will result in improved implantations. So yes, there are ways that we can, once we find out you have endometriosis, or if you've had a positive BCLL6 expression or Receptiva DX expression, by treating with prolonged Lupron, we can actually see an effect. And this is part of my interest in it. Now, can laparoscopy help for those who show up to be positive? The answer is absolutely. So by using laparoscopy or a GnRH agonist, showed improved outcomes. 79% of these folks got pregnant, and 64% had a live birth rate. And those BCLL or Receptiva DX positive patients treated with Lupron showed the highest pregnancy rates and live birth rates. So yes, laparoscopy helps endometriosis. Treating with Lupron long-term helps. And you can treat the patient's BCL6 positivity, even if, and this is, I'm not suggesting this, but even if they aren't surgically diagnosed. But in this study, they actually just looked at those folks who did not get pregnant with IVF. Can you subsequently, what's the effect of treating those folks in terms of outcomes? The answer is there was a marked improvement in their outcomes. So all you folks on Instagram, jump over to Facebook Live. I'm doing a little talk here. So how do you perform the test? Basically, it's performed by a biopsy. We place a small straw inside the uterus. We take a sample. It's usually done in a natural cycle on day 7, 8, 9, or 10, or in a mock cycle, it's done 7, 8, 9, or 10 days after ovulation. On a mock cycle, you do it 5 to 10 days after the start of progesterone. Unfortunately, the test is not inexpensive. It's $700. And then they're throwing in some other markers for another $125. So you're looking at $1,000 by the time you look at this. or more. So again, you have to weigh whether everybody should do this test or some people should do this test. Symptomatic people should do the test. But I think not everybody should do the test because, quite frankly, endometriosis is not that prevalent to suggest, that more than that 50% of folks who are infertile have it. So it's much less than that. So I'm not quite sure that's the best thing. What's another way to test for they've tried in the past to figure out whether or not a person has endometriosis without doing surgery? And that was magnetic resonance imaging, or MRIs. The problem with that is that it's only a very specific area that the endometriosis seems to correlate with changes in the MRI. So really, as a tool, it has not been found to correlate with surgical findings, and the sensitivity was less than 70% of the actual. So it's not really a very specific. Other methods, as I mentioned before, you can use a tumor marker called CA-125. It's probably the most valuable marker we have. There are lots of other markers that are available to follow a person who's been truly diagnosed as having endometriosis with surgery, and then to follow the recurrence of that. Now, whether or not the I haven't seen a study looking at CA-125 versus Receptiva DX. That would be an interesting study to see which one. My suspicion is the CA-125 is a lot less expensive, easier to do. It's a blood test versus the Receptiva DX is an endometrial biopsy. So how do we treat these folks? Well, if fertility is not the key, and simply pain, because remember, the big issue with endometriosis is pain, then fertility, but it's really pain. So one of the easiest and cheapest way to treat patients with endometriosis is with continuous birth control pills. It works with or without the addition of non-steroidal anti-inflammatories like Tylenol, Motrin, Nanoprox, even aspirin. These can be used as a way of treating these patients even without a surgical diagnosis. So you can do that. I did mention Lupron. You could also use Citratide, Ganirelix. Again, these are short-term therapies. You could use aromatase inhibitors like letrozole as a way of knocking down the body's production of estrogen. Why does that help? Well, because estrogen feeds endometriosis. Elagolix, the new Orilissa that's out there, is another way of treating, but there's no data that says the Orilissa is any better than birth control pills in terms of its help on these patients. But none of these pharmacologic agents will improve fertility outcomes in the setting of endometriosis. In other words, treat the endometriosis. This is a little bit counter to what I said on the other slide, because this is a little older study. I think this was, these are all 2020. I try to get current studies. There may be an improvement, but certainly surgery is probably your number one. There's an oral gonadotropin-releasing hormone receptor antagonist that's being tested, I think, in Europe right now. Again, they have found that it does reduce the endometriosis-associated pain in a dose-response manner. And you can see in the slide here, just look at the bars going down, down, down. That means that those folks had less pain over time when they were on these medications. So we do have ways of managing these folks. Now, pain in endometriosis, man, oh my gosh, there's so many studies looking at how endometriosis, impacts the pain system, modulation system. Nociception just means pain receptors, and these endometriotic lesions create inflammation. This neurogenic inflammation affects the peripheral nerve endings, which these in turn are registered as pain. But here's the odd thing. In some folks, a very small amount of endometriosis elicits a huge amount of pain. And in others, a huge amount of endometriosis elicits no pain. So the main issue here then is that even a little pain is worth examining, and that you can get help, and many of the studies and many of the treatments are all about managing pain and then infertility. We're going to talk about infertility in the last installment in 2 weeks. Right now, we're just talking about the management of the endometriosis pain. So it's a chronic endometriosis is considered a chronic and debilitating condition affecting about 10% of women, about 30% of infertile women. Recent studies evidence of there's a mechanism, as we could see here, through the various nerve bundles. This is the spinal cord, and it's looking at the various places within the nerve where the bladder, the colon, and the uterus, which is where endometriosis implants, will then affect the different levels in the spinal cord of the nerves, that affect the pain centers. And then what happens is that this inflammation, this neuroangiogenesis, all of this creates this chronic syndrome. And again, the hard part for folks is that they have to think about, well, do I get my infertility first taken care of, or my pain first taken care of? But that's something we can talk later. Inflammation of the immune and activation of the immune system by endometriosis. You'll find that CNY does a lot of work with immune therapies aimed at generalizable management of the activation of the immune system, the negative pathologic activation of the immune system. So certainly the human endometrium displays features both structural and functional that initiates gene transcription, and that's initiated by concentrations of estrogen and progesterone. And there's a cascade of events, and that the local increase of inflammatory mediators are associated with responsible for tissue breakdown, which really can negatively affect the patients. So the innate, our own built-in immune system is a gatekeeper to reproduction. Today's talk is not on the immune system, but it is related and has been related to I'm going to go backwards here. It's not letting me go backward here. Sorry. It has been related to endometriosis, and there are many cytokines and other inflammatory products that are activated when a person has endometriosis. Now, I've been talking for about 30 minutes. It looks like I'm not going to get anywhere near done what I'd like to talk about. But I guess the bottom line for folks that I would like you to follow, and I know some of you folks have come in a little bit later, so I'm going to review with you, is we're talking about endometriosis testing. We're talking that they were looking for probes over the years. What they ended up with is a factor, BCL6 overexpression, that is associated with inflammation of the uterine lining, and this is associated and has been associated now through this test with the presence of inflammation, one of which could be endometriosis. They've looked at it in terms of its positive predictive value for those patients who should have surgery, and it seems to be okay. Oh, thanks, Lindsay. The other is they've looked at it for those patients who had failed IVF and they were not successful. They've looked at it as to be associated with unexplained pregnancy loss, so recurrent pregnancy loss that's not understood. So again, endometriosis plays a role there. There are, of course, everywhere in medicine there's controversy, and I like to always look at the controversy, and they're just saying there's not enough studies that have been done. They've looked at, can we reverse this with the use of something like Lupron after surgery or Lupron even before surgery? And the answer is you can. And it does seem, although small, it's a small abstract, to affect implantation failure. So there's some hope that it's a good predictor of that. And then a big study, they looked at the outcomes of the failure, IVF failure, who tested positive. They found that they could reduce that with treatment either by laparoscopy or by using a Lupron. I explained how to use the test. I explained the cost of the test. I mentioned that there are other modalities like the MRI, CA-125. These are other modalities that can help you detect or associate with the diagnosis with endometriosis. So again, that's something you can look at. I talked about really the main treatments are either surgical plus hormonal or anti-hormonal, or long-term hormonals in the form of continuous birth control pills and pain relief and pain mitigation. I've talked about a new drug. It's an oral gonadotropin-releasing hormone receptor antagonist. We're not there yet. We don't have it yet, but it may be something that we can use. Or this may be the progenitor of Orilissa, actually. This may be the progenitor of Orilissa as an oral antagonist that will help reduce some of the pain, which is good. Pain, of course, is a big issue in endometriosis, and there's a lot of physiology associated with it. And then also the immune system is involved in the pathology of endometriosis. So you'll see that a lot of our approach, if you look at the CMY fertility approach to the management of IVF patients, you could either do a hell of a lot of testing, which we can, or you could do treatments based on sound principles associated with either infertility, recurrent pregnancy loss, or both. And that's another option. And you'll find is that we kind of lean towards, as long as it's safe, let's treat folks with, because we do know there's a lot of unknowns out there. By pre-treating them with this, we may get pregnant, and no one really cares whether the diagnosis as long as you have your baby. I mean, the diagnosis is the diagnosis, but what you really want is a baby. We have all night with you, any doctors or nurses. Lindsay, you're amazing. So that's Lindsay. She's saying I should keep going. I again mentioned about that. I honestly, I think, I mean, I know we're not voting on this, but it's, as I said, it's been over 32 minutes where we discuss this. And typically I'll stop here. I'm gonna continue this. I mean, every other week I'll keep building on this, and all of these are recorded. But I think at this time I'd like to help some folks personally, because some of you don't want to listen to a lecture, and you'd rather just kind of ask me questions. So why don't we do that? Why don't we do some questions? And thanks for listening to me talk about endometriosis. Okay, is adenomyosis the same as endometriosis, and it can cause infertility as well? This is Catherine. The answer is yes. Adenomyosis, though, is a location. Adenomyosis is endometriosis in the muscle of the uterus. Endometriosis itself is something that's outside the uterus typically. Both of them are inferred to have an impact on fertility. What are my thoughts on second beta of 21, no tubes? Well, Bianca, if you have a positive pregnancy test, it's the trend. And by the way, back folks on Instagram, I'm back live. So if you have questions, please feel free to talk to me. Okay. I don't know how to put this down here, but that I just do. I'll just say send. Okay. So if you guys have questions, please. No, I did it again. Sorry about that. Okay. So if your beta is positive and it says it's positive, then it should double in about 2 days, double in about 4 days after that, and etc. I would continue getting the test until either it stays flat, goes down, or goes up and you're pregnant. My NP at Albany said to avoid surgery and its risk. I had LAP in 1.5 years ago. I lost that. Sorry. So I can ask to be treated for endo without doing any endo tests. I failed one fresh and one frozen embryo immune for protocol. Well, Brandy, you can ask anything you want to ask, but in your case, I want you to understand this. The treatment for endometriosis is surgical. That's the treatment. The other treatments are mitigating things. They'll lower or slow down the recurrence. But I would certainly, if you've had that history, I would certainly, Brandy, consider getting surgery first. Taryn, I will be having laparoscopy after 3 failed transfer. I did have endometriosis on laparoscopy found about 3 years ago. Would it be worth it for me to use Lupron while waiting for my surgery? I think the answer is yes, and it would. However, it may be harder for them to find the actual lesions in your pelvis because they tend to be shrunken, and then they'll come back. Janae, I hear a lot about silent endometriosis, but not sure I understand exactly what that means. What is the protocol for treatment of silent, Janae? Well, the silent means that you're not feeling a problem, but when we do diagnostic laparoscopy, we find all kinds of endometriosis. So you were silent to you, not silent to your body, not silent to your fertility, but silent to your perception of pain or a mass. The reason you want to, the way to know you may have this is symptoms, and if you don't have it, then the other way to know it is unexplained IVF failures, recurrent pregnancy loss that are unexplained. Then it's worthwhile taking a look, doing the surgery, figuring out what's going on, and the treatment is diagnose and then treat. Is there a treatment for adenomyosis? There are, Catherine. I did a whole talk on adenomyosis. You can look it up. There are treatments for adenomyosis. Some folks say surgically, some say long-term Lupron suppression. And then get pregnant, and then you may end up having surgery. Unfortunately, some folks even say that the treatment for adenomyosis down the road after your babies are done is hysterectomy. So there are treatments for certainly the pain associated with it or the distortion associated with the adenomyosis in the uterus itself. Oh, I don't know if I killed you guys here. Nope, let me see. Does anybody have a question here? I'm on level 3 protocol, and Levaquin and Flagyl is making me sick to my stomach. Baseline is in the 24th of this month. What should I do? Call the nurses. Call the nurses, and they can possibly substitute something. I have a very low AMH. How probable is AMH blood work can be inaccurate? It is not inaccurate. AMH is not inaccurate. It is accurate. It's a good test. It's actually the best test we have for ovarian reserve. Welcome, folks, on the Instagram. You're all coming back live and strong. What are your thoughts on HLA matching and recurrent pregnancy loss? It's too broad a subject right now. That's a whole lecture in itself. I'll reserve that to another time because it's just too broad as a subject. 3 failed transfer, 1 block 2, BLAP HIS scheduled for November 30th. Good. Yes, do that, please. No symptoms to suggest endo. Trey Cox, absolutely do that. I have low MH, but you can get pregnant. Absolutely. Yeah, I hope no one tells you that if you have low AMH, you can't get pregnant. A lot of people are misunderstanding. It's a marker of ovarian reserve. It is not a marker of fertility. Fertility is the ability to get pregnant, right? So don't confuse those two. I have a lap back in December and cleared stage 4 endo. Good. I've had failed FET and 3 failed IUI since. That seems odd. Is it possible it didn't clear? Well, that's a great point. When you do surgery for endometriosis, you never get rid of it. All you're doing is damping, like the weeds in your backyard. You weed, but they always seem to come back. But you like to weed them so it looks nice for a little while, and then they come back. Well, that's the same with endometriosis. You can't get rid of all of the endometriosis. So yes, it can come back. What supplements, vitamins do you recommend to help increase the chances of frozen embryo transfer? Download our family building guide. It's on our resource page at CNY Fertility, and they're all listed there. It Starts with the Egg is a wonderful book. Another thing you can read, that's a great place. Well, cytokines, Jessica, there's a huge number of cytokines that are out there. And yes, there are tests for cytokines, but I'm not quite sure what you're asking as it relates to what we're talking about. Had cycle day 1 today for Receptiva this month with meds. Tried last month, but my progesterone never got high enough. 3 failed FETs, hoping for answers. Yes, Adelaide, have you have endometriosis? Okay. No, I'm sorry. I don't know, Adelaide, do you know if you have endometriosis, or you're just trying to find out if you do? How long after a lap does endometriosis grow back? We like you to get pregnant. No waste nutrition is. We like you to get pregnant within the 6 months of surgery. Okay. Carla, I'm currently on Lupron for stage 4. I thought you weren't supposed to get a period. I'm on my 3rd period since my something. Yeah. Well, Lupron, you may be bleeding for another reason, Carlos. You should see your doctor. And Jessica, you're right. Cytokines are inflammatory markers, and certainly we don't have a plethora of tests we can do. The Receptiva seems to be the new sweetheart on this. How long do you have to wait after lap to do a round of IVF? I am Tiki Amor. I would say after laparoscopy, 4 to 6 weeks is not unreasonable. 4 to 6 weeks. All right. Any other questions about anything? Okay, all right. All righty, we're talking about endometriosis, but if you have other questions, please jump on. Hey, Joshua, Dr. Banerjee's on. Hello, my friend. Hopefully I'll talk to you tomorrow. Have you seen good odds of success with Depolupron? Yes. Doing our IVF, my egg, but my AMH is very low. What do you recommend? Don't know what that means. Oh, yes. Any diet recommendations for endometriosis? Yes. As a matter of fact, I do. And that's going to be the subject in 2 weeks of my talk because I couldn't get to it. We're going to be talking about endometriosis, traditional Chinese medicine, diet that help endometriosis, and dietary factors that contribute, they think, to endometriosis. So that's something should be really exciting. I realize a lot of times I put too much information on the slides, and so we get lost in that. But yeah, I'll be talking about diet, traditional Chinese medicine, endometriosis, and then the last discussion that I'm going to have on this topic, which is in about 4 to 6 weeks, is how does endometriosis affect fertility? That is something that we're sort of getting there. Carla Poo, I'm currently on Lupron for stage 4 endo. I didn't think you were supposed to get a period. What could be the reason I'm still bleeding, Carla? I think you need, I think you asked me that on Facebook, and now you're asking me it on Instagram. It's the same answer. You need to get examined. You should not continuously be bleeding on Lupron if there isn't another reason. Lindsay, it's hard to eat 1 meal a day when you're pregnant, bacon, eggs, butter, beef, and ice cream. Well, don't do that, Lindsay. You don't need to do that as a lifestyle. Gear your diet more towards low carb, 50 grams of carbs a day, lots of green above ground vegetables, good fats, healthy meats. But no, you don't need to do 1 meal a day when you're pregnant. I don't think. Well, everybody has an opinion. My opinion is that's one way of doing things, but it's not the only way to do things. And if you're not doing well, then don't do it. If you're not doing well on something, then don't do it. And I know Dr. Kiltz loves keto, and I get it. I have a slightly different view of how to manage the nutritional aspects of fertility, and we'll be talking a lot about that in the future. Yes, Dr. Kiltz's keto is his book, his website. So that's a big deal, and it's one approach. And that's the great thing about CNY is we have many approaches using lots of data from many sources to manage our patients. And that's what medicine and science and and is all about. Medicine is a practice. It's not a science. It's a practice. Yeah. All righty. Lots of people joining. How about some more questions on the Instagram side? You're welcome, Carla. Okay. I was told by one of your practitioners in my consult to get a laparoscopy before egg freezing, but in other consults I have been told it isn't necessary. Can you clarify? No. You don't need surgery before egg freezing. Yeah, you do not ever need surgery before egg freezing. Absolutely not. At least that's my opinion. My HCG was negative on day 10 after embryo transfer. Could it be early for results? See, Marisette, I like people to take their blood test 2 weeks after their transfer because they have that doubt. And I don't want you to walk around with that doubt. There's no harm in going back in 4 days and retesting it. Stay on your meds, especially if you feel pregnant, breast tenderness, back pain, that kind of thing. So yeah, if you feel like there's something going on, you certainly can request another test, especially if you have a gut feeling that you are pregnant. Charlene, just had a chemical pregnancy. Is this a good sign that I can get pregnant? Yes. Yes, it is. 70% of all pregnancies end in miscarriage. 70% to not, even more than that end in miscarriages. So, and a biochemical pregnancy is a miscarriage. We give it a name like biochemical. After a failed FET, do you recommend Orilissa or Lupron? Yes. Yes. So yes, I do. What should your blood number be at 2 weeks? I'm not sure what number you're talking. Oh, pregnant number? No idea. You can look that up on the internet, Lindsay. Yeah, there's no idea that could be in this brain. Yeah, that's a hard thing. Once it reaches 1,000, folks, once your blood levels reach 1,000 and you can see it on the ultrasound, then I'm not sure what the blood test is going to tell you. So Rebecca, I'm scheduled for a pre-op for LAPIS with my OB, but first available is the beginning of November. We had 2 early losses. Should we proceed with the retrieval cycle and attempt a fresh transfer or wait to transfer after we find out what the... No. You can do, I would do an egg retrieval and a freeze all the embryos, then do the surgery, then put them in. Okay. Which one? The Lupron or Orilissa? Either one is fine. Either one is fine. They do the same thing. So, or they're just 2 mechanisms doing the same thing. Tara, I just had a failed embryo transfer. It was my first. What should I speak to about adding Lupron or anything to my protocol this upcoming cycle? I was to start with another cycle once my cycle starts again. Well, have a doctor do a consult. By the way, folks, if you have questions, create a consult with a doctor to review your chart. That's what we do. That's exactly what we do. In order for you to have a thoughtful review, many of you want to jump in as fast as you can to another cycle, but sometimes being judicious about reviewing and seeing what issues you should add, etc., I think that's worth doing. What do you think of mini IVF women over 40? I think Leanna Fitness is that it's a good idea. I called for a consult today, but they told me nothing until the very end of September. Tara, that's probably not right. Usually it's December, I think, is our next available. I don't think it's the end of September. But what you can do, Tara, is get on a waiting list. Now, again, I didn't know who you called, but my suspicion is that the waiting list is a little longer than the next 2 weeks, I would think. But the end of September is 2 weeks away, so it's not that far. Why do you want to use those 2 meds after a failed frozen embryo transfer? 2 meds. What 2 meds, Lindsay? I'm not sure I understand, Lindsay. Yeah, definitely, folks, if you want to say A lot of times when we wake up in the morning, we go to work, we look for gaps in our schedule and we call up the call center and say, hey, fill our gaps, with patients so that they can move up on their appointments. So definitely be on the cancellation list or the gap list, whatever it's called. I named two of them. Oh, the Oralisa or the Lupron. Those are post-surgical treatment for endometriosis. Oralisys is oral and Lupron is injectable, and they're just ways of reducing estrogen levels. Lots of people are joining now, and I'm sorry, folks, we do start our talk at 4 p.m. to 5 p.m. I think many of you may have thought we start at 4:30. We used to, but we now start at, just so you know, we start at 4. And by the way, I'm Dr. Magarelli, CNY Fertility, Colorado. If you guys want to come out and see me, we'd love to have you. We're growing. We're just having a great time developing the CNY Western Front. See Maria, my sister is my egg donor, and we're scheduled to have an egg retrieval next month. It's been a long time coming, but we're so excited. I think that's fantastic. What about blocked fallopian tubes? The best treatment for blocked fallopian tubes is IVF. Why? Because we take the eggs directly from the ovaries and place them inside. After we fertilize it, we place the embryos inside. Hello, B. Noble Jack. Welcome back. The journey through IVF. See you in October. Make sure you come say hi, folks. Especially if you've been on my Facebook Lives. You tell the nurses, hey, I want to say hello to Dr. Magarelli. We have wonderful Dr. Fink, myself, as the docs there. But, if you want to say hi, please do. Hey, B. Noble Jack. How many failed transfers would you consider within the norm? Or after how many failed transfers would you consider for testing or trying something new or different? Paula, I think 2. The average success for IVF in a 20-year-old is 3 IVF cycles equals the vast majority of folks will get pregnant. Of course, it takes more as you get in your 30s and even more in your 40s. But I think after 2 cycles, we should have gotten it right. It may not, don't change anything, but at least explain what you're doing. Have a better understanding. Everybody. Oh, thanks for the kisses, everybody. Look, I really appreciate that on Instagram there. Don't change things. Understand things. That's the goal of your consult. Is it okay to do back-to-back transfers? Absolutely. Your body's prepped. Your style is prepped. You're ready to go. Absolutely. Yes. Oh, thanks for the kisses. Okay. Oh, pretty pictures. Any other questions? If all embryos were aneuploid, should I go to the egg donor or more batching? Well, Barbara Santon, it depends on your age. Just if you're in your mid-40s, then yes, go to egg donor. If you're in your mid-20s, then it's just a bad cycle. Just had endometrial stage 3 removed and want to do back-to-back transfers. Any issues? No issues at all. Oops, want to do back-to-back retrieval. Again, no issue at all. Do back-to-backs. Back-to-backs just mean you do 1 cycle, you get embryos, you store them. You do a 2nd cycle, you get embryos, store them. Don't do a back-to-back where you're doing the 2nd one and using the embryos from the 1st one to try to fit it into the 2nd one. I don't know where the heck that idea came about, but it's the worst part of everything. It's the worst part of fresh. It's the worst part of frozen. So if you're doing back-to-back, store them. Then come up with a plan to put them in. Dariana, yes. After your transfer, the hardest wait is the 2 weeks waiting for your pregnancy test. But think good thoughts. Do acupuncture. Do your serum vitals. Avoid alcohol, tobacco, drugs. Don't let anyone smoke around you. These are things that you can do. I consider pregnant with a low beta of 21. You are pregnant. You can't get that hormone, the Queen 18, without being pregnant. Okay? You can't get that hormone without being pregnant. So yes, if you've got a positive, and you just watch the pattern. Brislin Gale, welcome and join me. I was diagnosed with stage 5 endo. I don't even know what that is. What is the best days after your cycle to have sex to conceive? Again, I don't know how those two things are related. You should do probably, depends on your age, not the time for sex, but it depends on your age. Yeah, I'm not quite sure I'm understanding about stage 5 endo. I think the treatment for severe endometriosis, if that's what they mean by stage 5, is IVF. If you have that much damage from endometriosis, the likelihood of sex working is very low. Okay. Okay, I think people are wearing out here, running out of time. Oh yeah, we only have about 5 minutes. So today's topic was on endometriosis. Let me throw this back up here, show you. Where are we here? Am I here? Let's go here. No, let's go here. There we go. And then let me jump back up here. So next time we talk, we're going to be talking about traditional Chinese medicine. Someone asked the question, how often should you do acupuncture after transfer? Well, actually, you should do it during. It's called the Credenda Magarelli Acupuncture Protocol. Go to go to eastwindsacupuncture.com, look up the protocol. We're going to be talking about acupuncture. We're going to be talking about diet, the endometriosis diet next time. We're going to be talking about the various ways, the team approach for managing it. And then after that, we're going to be talking about infertility. So we have a lot ahead of us. I thank you for joining me. Please join our CNY fertility support group. Vanessa wonderfully put it on our Facebook Live, but maybe Vanessa, you might want to do it on the Instagram feed. Put that same link on the Instagram feed. I'll be discussing the Chinese medicine in 2 weeks. Next week, we're going to be talking about just question and answers. Yes, all of my lectures I record. They're all recorded. The Instagram feed is recorded. The Facebook feed is recorded. The YouTube, it's all on the CNY Fertility website. Or go to Facebook, CNY Fertility. You can find them there. And so next week, we'll be talking just questions and answers. I hope you're enjoying this crazy Italians discussion of all kinds of stuff. It's my pleasure to be part of the CNY family. I thank my CNY crew. You can't do it without them. I certainly thank Dr. Kiltz for what he created and is ever developing. Yes, everything is recorded. So this is Dr. Magarelli, CNY Fertility Colorado. Love to have you come and take care of you. So I'm going to sign off because my hour is done. And thank you so much for being a part of this wonderful evening. Thanks, everybody. Take care. Bye-bye.